Hemodynamic monitoring for the RN student. This will be the review from class and the course medical surgical textbook. The phlebostatic axis marked on the patient's chest is the precise anatomical points of origin of the hemodynamic pressures being measured. Calibration and leveling should be done every shift and when the patient, bed, or transducer moves. This ensures that accurate pressures are recorded. The patient does not need to be flat, however they must be supine. The nurse must document the degrees the head of the bed was placed when zeroing the stopcock. Alarms are safety devices that warn of a disconnected line or hemodynamic instability. Alarms should always be investigated by the nursing staff. To keep patients safe, only suspend alarms when drawing blood or changing tubing and never turn the alarms off. Preload is the amount of stretch on the myocardial muscle fibers at the end of diastole. Preload is the volume of blood present in a ventricle of the heart after passive filling and atrial contraction. Preload occurs during diastole, and it is the combination of pulmonary blood filling in the atria and the stretching of myocardial fibers. Preload is regulated by the variability in intravascular volume. Volume reduction decreases preload, and preload is affected by venous blood pressure and the rate of venous return. The volume of blood in the ventricles then determines the stretch at any given time. Increased preload causes an increase in stroke volume, ventricular work, and myocardial oxygen requirement. So then while a decreased preload will cause a decrease in stroke volume, ventricular work, and a decrease in myocardial oxygen requirements. In the ICU, preload is measured by evaluating end diastolic pressure measured by the central venous pressure, which is the right atrial pressure for the right ventricle, and the pulmonary artery wedge pressure, which is for the left ventricle. Preload can be manipulated to improve cardiac output and myocardial oxygen with the use of fluid challenges, diuretics, and vasodilators. Preload increases slightly with exercise, overtransfusion, and excitement. A rule of thumb to remember is that increases in preload result in increased stroke volume in the healthy heart. Afterload in a nutshell is the aortic pressure during systole. Afterload is the resistance that the heart has to overcome during every beat in order to send the blood into the aorta. The resistive forces include vasoactivity and blood viscosity. Afterload to the left ventricle is aortic arterial pressure, and afterload to the right ventricle, pulmonary arterial pressure. Afterload to the left ventricle is greater than that to the right ventricle. Afterload, then, is the sum of all loads or forces against which the ventricle muscle fibers must shorten or push to eject blood into the arterial circulation. If afterload is increased, the stroke volume decreases, the cardiac output decreases, but the blood pressure increases. Increased afterload is reduced contraction. So in reality, the blood pressure would probably increase initially in response to the increased workload. An elevated afterload then may reduce the stroke volume. Another rule of thumb is that increases in afterload can decrease stroke volume, especially in the failing heart. Contractility is the force and velocity of myocardial fiber shortening that is independent of preload and afterload. So looking at this video, each time it goes down into the ventricles, that's preload, and when it leaves the ventricle, that is afterload. Positive inotropic stimuli occurs with medications such as epinephrine, dopamine, and digoxin, which increase the strength of contraction, myocardial work, and myocardial oxygen consumption. The opposite occurs with use of medications that have a negative inotropic stimuli, such as beta blockers. Cardiac output is the volume of blood pumped by the heart in 1 minute. Increased cardiac output may indicate a high circulating volume. Decreased cardiac output indicates a decrease in circulating volume or a decrease in the strength of ventricular contraction. The factors that determine cardiac output are preload, afterload, left ventricular afterload, right ventricular afterload, and contractility. The cardiac index is the amount of blood pumped by the heart per minute per meter square of body surface area. This is more accurate than cardiac output because it includes the size of the individual. Transducers are used in monitoring to convert the pressure changes in the artery, which is red, and central vein, which is blue. These pressure changes are converted into electrical signals, which are displayed as pressure waveforms on the monitor. Central venous pressure readings are used to approximate the right ventricular end diastolic pressure. The right ventricular end diastolic pressure assesses right ventricular function and general fluid status. Low central venous pressure values typically reflect hypovolemia or decreased venous return. High central venous pressure values reflect overhydration, increased venous return, or right-sided cardiac failure. In order to determine the mean arterial pressure, you take the systolic blood pressure plus 2 times the diastolic blood pressure and divide it by 3. The pulmonary artery pressure is the pressure in the pulmonary artery. Increased pulmonary artery pressure may indicate a left to right cardiac shunt, pulmonary artery hypertension, pulmonary embolus, pulmonary edema, left ventricular failure, COPD, or emphysema. Pulmonary capillary wedge pressure is known as PCWP or PAWP. The pulmonary capillary wedge pressures are used to approximate the left ventricular end diastolic pressure. A high PCWP may indicate a left ventricular failure, mitral valve pathology, cardiac insufficiency, or cardiac compression post-hemorrhage. Increased pulmonary vascular resistance can be caused by pulmonary vascular disease, pulmonary vasculitis, pulmonary embolism, or hypoxia. A decreased pulmonary vascular resistance could be caused by calcium channel blockers, aminophylline, isoproterenol, or oxygen delivery. The pulmonary vascular resistance is the measurement of resistance or the impediment of the pulmonary vascular bed to blood flow. Right ventricular pressure is a direct measurement that indicates right ventricular function and general fluid status. High right ventricular pressure may indicate pulmonary hypertension, right ventricular failure, or congestive heart failure. Stroke index or stroke volume index is the amount of blood ejected from the heart in one cardiac cycle. It is relative to the body surface area. It is measured in mLs per meter squared per beat. An increased stroke volume index may be indicative of early septic shock, hyperthermia, hypervolemia, or could be caused by medications such as dopamine, dobutamine, or digitalis. A decreased stroke volume index may be caused by congestive heart failure, beta blockers, late septic shock, or an MI. Stroke volume is the amount of blood pumped by the heart per cardiac cycle. It is measured in mLs per beat. A decreased stroke volume may indicate impaired cardiac contractility or valve dysfunction and may result in heart failure. An increased stroke volume may be caused by an increase in circulating volume or an increase in inotropy. Systemic vascular resistance is the measurement of resistance or impediment of the systemic vascular bed to blood flow. An increased systemic vascular resistance can be caused by vasoconstrictors, hypovolemia, or late septic shock. A decreased systemic vascular resistance can be caused by early septic shock, vasodilators, morphine, nitrates, or hypercarbia. Intravascular volume is the amount of fluid circulating in the vasculature. This can be affected by dehydration, diuresis, and volume overload due to heart or kidney failure. The Swan-Ganz catheter is also known as the pulmonary artery catheter and must have a central line that has an introducer port in order to insert the pulmonary artery catheter. As you can see that there are potential complications such as hemorrhage, air emboli, and infection. The thermistor connector is for thermal dilution measurements. It connects to the monitoring system to view the waveform during the insertion sites, and assessing the waveform is part of nursing care. The red line is the balloon port. A syringe is connected to this port and inflated in order to measure the pulmonary artery pressure. The balloon is at the distal tip and literally floats in the direction of the blood flow. The blood flow will carry the balloon through the right atrium, right ventricle, and into the pulmonary artery. You can see in this picture of the red port that the syringe is used to inflate the balloon. And this picture shows the balloon is inflated. The yellow port is the pulmonary artery distal port and will measure the pulmonary artery pressure and goes all the way through the line and ends where the balloon is. This port is connected to transducer tubing, and the waveform will identify where the balloon is floating in the heart. When the line is advanced, then the waveform will change. The distal tip of the catheter will sit in the pulmonary artery to measure the pulmonary artery pressure and the wedge pressure. The proximal infusion port is either a clear port or a white port and is used for drugs and fluids. The lumen exit for this port is near the CVP port. Here's an example of a clear port used for drugs and fluids. Do not confuse this with the blue port. The blue port is known as the proximal injectate port. The lumen for this port is approximately at the 30 centimeter mark. A transducer is connected to measure the central venous pressure. The sterile contamination shield keeps the external part of the catheter sterile. This one is attached to the central line. The white port can be used for giving fluids and medications. The brown port is usually saved in case the patient needs TPN. If the patient will not receive TPN, then the port may be used. One thin black line is 10 centimeters. Two are 20 centimeters. 3 black lines are 30 centimeters, and 4 thin black lines are 40 centimeters. Next is one thick black line, which equals 50 centimeters. The swan will go up to 100 centimeters, which is 2 thick black lines. This is a typical waveform progression as the pulmonary artery catheter floats through the atria first, then through the right ventricle and into the pulmonary artery. The balloon is inflated, which gives the pulmonary artery wedge pressure. Monitoring the waveforms identifies where in the heart the catheter is as it advances. This first one is the right atrial waveform, and it looks erratic, but this is a normal wave when threading a catheter through the right atrium. This waveform through the right ventricle says to me, "Oh heck no, oh heck no, oh heck no." The right ventricle is irritated, and if it continues, then lidocaine may be needed. The nurse will see this waveform going through the pulmonary artery. I call this the wee, whoops, my bad, the wee going up and then dropping down, oops, my bad. Saying this always worked for me to recognize a pulmonary artery pressure waveform. This waveform is the "I'm so mellow." It is only a temporary waveform to get a wedge pressure. However, it cannot stay that way because it means the balloon has remained inflated when it should be deflated after a pressure reading, which now can cause a pulmonary artery infarct. The nurse should not see this waveform spontaneously appear. It may be migrating, so call the physician. The patient was seen by the cardiologist, and because of his ischemia, history of an MI, and stent placement 5 years ago, they went to the cardiac lab for a right and left heart catheterization. The patient had several multi-vessels disease and needed coronary artery bypass graft surgery. The patient was taken to the OR and had a 4-vessel bypass and was recovered in the cardiothoracic ICU. Due to the nature of the surgery, the patient had a PA catheter inserted intraoperatively for additional monitoring. Now look at the numbers and interpret what do they mean clinically. Why would that systemic vascular resistance and pulmonary capillary wedge pressure still be high and cardiac output and cardiac index low? This is a sign of cardiac shock. Signs of cardiac shock include an elevated systemic vascular resistance and pulmonary capillary wedge pressure with a low cardiac output and cardiac index. The cardiac surgeon orders dobutamine drip as well as a nitroglycerin drip. What is the rationale for these 2 drips? The dobutamine drip will increase the cardiac output and cardiac index, and the nitroglycerin drip will decrease the systemic vascular resistance and pulmonary capillary wedge pressure, the afterload, of the left ventricle. Some effects of the dobutamine drip are increased oxygen consumption and potential for dysrhythmias. Nitroglycerin drip may decrease the blood pressure, so slow titration is warranted. At 2300, the dobutamine increased the cardiac output and cardiac index. The nitroglycerin decreased the pulmonary capillary wedge pressure and the central venous pressure to normal values. The patient continued to progress through the night and was extubated the next day. Here's another question. If a patient needed a volume expander and was acidotic, which crystalloid would be the best choice? Usually the best crystalloid isotonic solution that acts as a volume expander is lactated ringers. It also acts as a buffer in the presence of acidosis. What if the patient needed increased inotropy and increased systemic vascular resistance? Then what meds on this list would be appropriate? Dopamine would be appropriate, as would ephedrine, if a lesser response would be adequate. If the systemic vascular resistance is already too high, but the patient still needs inotropy, then what med would be a good choice? Dobutamine would be a good choice. If cardiac output is adequate, but the low blood pressure is due to low systemic vascular resistance, such as excessive vasodilation, then a pure vasoconstrictor would be ideal. Which would you choose? Here, phenylephrine or possibly noradrenaline would seem appropriate. The nurse is preparing to give fluids through these two lumens in a patient with a PA catheter. Is this safe? Yes, this is the proximal infusion port, and the nurse may give fluids and medication through the lumen hub. The lumen exit for this port is near the CVP. And this is the proximal injectate lumen hub, and fluids can be given. The nurse notes this waveform during a PA catheter insertion. Identify where the catheter is located. The right ventricle. Be sure to have some lidocaine nearby just in case. The PA catheter has just been inserted. What does the nurse anticipate as the next order before using the catheter? Call for a chest x-ray because there is a risk for improper positioning. This x-ray actually shows the improper positioning of a pulmonary capillary wedge pressure catheter in the distal branches of the pulmonary artery. A PA catheter was placed for a patient with mitral stenosis and regurgitation and was given furosemide for pulmonary congestion and nitroprusside for afterload reduction. Then the nurse notices a drop in the pulmonary artery pressure and the pulmonary artery wedge pressure. What should the nurse do next? The nurse should immediately assess the blood pressure since nitroprusside and furosemide can cause severe hypotension from a decrease in preload and afterload. If the patient is hypotensive, the nitroprusside dose may need to be reduced or discontinued. How would you assess the afterload status of the left ventricle? Calculate the systemic vascular resistance and the systemic vascular resistance index. The SVRI helps to differentiate and optimize vasopressor therapy as it is an estimate of left ventricular afterload. The cardiac index is part of the formula to determine the SVRI. Nursing assessment shows that the SVR is very low. Why would dopamine and norepinephrine be given? Decreased systemic vascular resistance means vasodilation, and if it is very low, then it could mean massive vasodilation. Dopamine and norepinephrine would increase vasomotor tone as well as increase blood pressure. Blood pressure in the right arm is 144/84, and the arterial line is 88/50. What are you going to do first? Check the level of the transducer as it must be level with the phlebostatic axis. Relevel and re-zero the system. Once that is complete, then recheck the arterial and cuff blood pressures. What symptoms would the nurse assess in a patient with this CVP reading? Peripheral edema and jugular vein distension are seen with hypervolemia and right ventricular failure. The CVP is a direct measurement of the pressures of the right side of the heart.